Howdy YouTube family, it's Bolt CRNA coming to you again with another day's topic. So today we're going to be talking about the differences between ICU nurses and ER nurses. We've got a long-standing rivalry between the two, and we're also friends. So it's like a friendly camaraderie really, and a rivalry all in one. So today I want to talk a little bit about that. Let's get into it. The scenery is a little bit different today because I'm hanging out on my new rooftop pool, which actually I'm going to do a video that's going to upload. It may upload before this, I'm not sure, but it's essentially showing you guys the difference between my house in Turlock versus my house here in the Bay Area, Santa Clara. So go over there and look at that video if you're interested in what this pool looks like up here. So the differences between ICU nurses and ER nurses. Now, I'll say ER nurses are very good at juggling a lot of different stuff. They can juggle a burn patient, a pediatric patient, a geriatric patient. They can juggle situations from some kid stubbed their toe to guys having a heart attack at work, and to a patient who hasn't had dialysis and is having symptoms from that and has to come into the hospital. So they juggle a lot of different types of issues, and some of them are kind of silly issues where it's maybe a drug seeker or a homeless person looking for a free meal, and then a very serious issue like a child drowning or something. So they juggle all these same things all at once, and they really don't know what they're going to get. So that takes a very particular type of personality. I have a lot of respect for ER nurses because that's not a personality I have. That's not something I enjoy. I could probably do that if I needed to do that, but it's not what I like doing. I wouldn't be great at it. So on the opposite spectrum, you have ICU nurses, which is what I was. ICU nurses are much more structured. We like organized situations. Things can get intense sometimes in the ICU, codes and patients can go bad very quickly, but we like to have all of our supplies in an area we know where they're at. We like to have our team all there who helps us. We all know what roles we play, and usually like a code in the ICU is very organized and structured. People are not panicking. People know where to go and what to do, and everyone just handles it. And so it's a much smoother, easier process, and that's because ICU nurses like that organization. They like to know these drugs are kept here, and this is our protocol for this, and also ICU nurses know a lot about their patients, so they're not confused by what's happening with a patient situation. They probably have been watching all the labs and the trends of the vital signs change, and they probably are anticipating the patient may be coding soon. So they may already have the code card in the room and be, counting down the minute till they assume it's going to happen, and the rest of the team may be alerted as well. There were definite times where I knew my patients were not doing well, and I knew things were going in a bad direction, and I was taking a lot of, starting different treatments and calling different physicians and nurse practitioners on the team and talking to my charge nurses and stuff, trying to head off this direction that I could tell the patient was going in. But sometimes you just can't do, like you're throwing everything at them and they still, sink. So those are situations in the ICU where it's a lot more structured, and I really appreciated that about the ICU, and that's mostly my type of personality. Another big difference between ICU and ER nurses is the patient load. So in the ICU, you really only ever want 2 patients. You never want more than 2. In fact, we really just want 1 patient. I did what I could to take the most critical of patients, like balloon pump patients or CRRT patients or maybe a fresh cabbage patient. I preferred those types of cases because I knew that it would be a one-on-one case and I would not have any other patients, because I really just preferred 1 patient at a time. Whereas in the ER, you easily may have 4, you may have more than that, you may have 3 at one point and then discharge 2 and then have 3 more admitted and then discharge 3 of those and admit 4 more. Like, your schedule is so hectic and crazy and fast in the ER. You juggle a pediatric patient, and then your next patient may be geriatric or whatever, whereas in the ICU, we segregate out and specialize so that if you want to do pediatric ICU, you are specifically pediatric ICU nurse and you're trained on peds, and those are all the patients you take. You don't take adults. Or you're an adult ICU nurse and you take, adults 18 or so up to geriatric age. So those types of patients and their physiology will be a little similar. We also subspecialize for like burns and neurosurgery and cardiac. So anyway, we break the departments down into all those different areas, and different ICU nurses will specialize in those areas. So we even subspecialize to that point, to where you just become extremely smart in that area of critical care, but you may not be great at, pediatrics if you're really good at adult burns. So they're just two very different areas. Whereas in the ER, a lot of times there are some huge major ERs that kind of segregate out their ER units a little bit, but in general, most ERs are going to be a big grab bag of everything, and you kind of just have to be able to handle a lot of different random things that may come your way. Now, this next point I know intimately, because I used to receive report from ER nurses about my patients who were having to be admitted to a critical care unit. So I can tell you from experience, ER nurses want to know about bare minimum about that patient that they have to know. They're not interested in knowing a whole bunch of other stuff. They're not interested in extra data. They're not interested in extra labs. They're not interested in, the family history, none of that stuff. Like, they don't want to know. They don't care what the patient ate before they came to the hospital. Like, they don't care. Whereas when you call the ICU nurse, and I know ER nurses hate this too, they hate calling a report to us, because I wanted to know everything about that patient. I wanted to know what the chest x-ray said. I wanted to know what the most recent CBC was, and I want to know what the last CBC was, and I want to know the trends. I want to know how many bags of fluid have they had so far. Have they urinated? How much did they urinate? I want to know the color of their stool, if they had stool, like all that kind of stuff. And ER nurses would be like, I don't know or care. Like, they would obviously get frustrated with us. And it wasn't just me and specifically me. It's a trend between all ICU nurses and ER nurses. So I know that ICU nurses can be annoying in that sense, that we want a ton of data. And then when we get the patient, I know we get a ton of data from the patient, and we learn everything about them and memorize, every freckle they've got and that kind of stuff. And then when we call off report to a step-down unit or to a telemetry floor when the patient's healthier and they're able to discharge or transfer out of the ICU, I know the med-surg nurses and stuff get so annoyed because we give this very thorough, super long report, and they're like, I don't care, I have 8 patients, and I really don't even care what this patient's name is. I'm going to throw some pills at them, and I'm going to try and get home today by 7:30 p.m. So that, I know that's the reality situation. So it's kind of funny when you talk about report between an ED nurse and an ICU nurse. You really see a very big, stark difference in the way that they approach their patients and the way ICU nurses approach their patients. Which that leads into my next point about the difference between ED and ICU. So ED nurses are interested in treating the most emergent thing going on with the patient. They're interested in treating it the fastest way possible and hopefully discharging them to go home, and they can follow up with their primary care doctor at a later date. Or if there's no way they can discharge them home, they want to admit them to the hospital right away, get them onto their floor, whether it be med-surg, peds, ICU, wherever they have to go. They want to admit them to those units and get them gone. Like, their goal, their focus is not to treat or maintain this issue. The issue, their goal is there an emergency? Is this life-threatening? What's life-threatening about it? How do we fix this life-threatening thing? And then let's send you on. And if it is life-threatening, I don't really want to treat the long-term life-threatening issue. I just want you right now to be alive so I can ship you somewhere else and let them manage you. So that would be frustrating with ED patients coming up to the ICU, because they would be critically ill, and they would maybe, like, say DKA was a very common example. Someone in DKA needs a lot of fluid hydration. There's a whole protocol of different series of events that have to happen in certain sequences to get their fluid levels up to the correct place, to get their electrolytes back in order. You have to start infusing lots of different potassiums and things like that. And so the ED was, at least in my experience, very infamous at trying to get as little of that DKA protocol started. Insulin drips, all that stuff, they didn't want to get any of that started. They wanted to get them to the ICU as fast as possible and let us get it all started. So, and I know there's logistics between why it's harder for them to get that stuff started, and they don't really titrate meds, and they don't really manage a lot of that stuff in the ED, so it's trickier for them. And they're juggling multiple other patients. So there's reasoning behind it, but it would be frustrating for the ICU for us to get them and them be like 4 or 5 hours been at the hospital and almost nothing started yet on their treatment plan, but like 1 liter of fluid or something. And with the ICU nurses, what usually draws those types of personalities to the ICU, they're people who they don't want to just treat the emergent issue right off the bat and send somebody on. They want to take care of the critical issue going on. They want to maintain that. They want to see it through, maybe over multiple days or even weeks, until you've gotten the person through that critical issue or whatever disease process that brought them in that makes them in critical condition. And then you move them on. Once you can see they're on the uphill swing of things and they're moving in a better direction, and they need just a little monitoring and very minimal interaction at that point, just to make sure they don't relapse into a bad condition again, then you move them onto a med-surg floor. And a lot of times ICU nurses like to take them to the med-surg floor, get them into their new bed, get them hooked up to their new stuff over there in med-surg, just really close the loop on that patient care, where the patient knows, like, I'm better now. I'm feeling better. The nurse can see that they're doing well. And then at that point, you're like, okay, I feel free to release control over you, and I'll go back to the ICU again. But yeah, so ICU nurses, we like to get involved in the complex pathophys. We want to get involved in the hardcore details of what's happening in a condition. We want to treat all of it. We want to use all the meds, all the machinery, and we want to do all of it until you get better. So in the ED, they really don't want to get involved with family members. They're not there to get to know the family members. They're not there to get involved in this long-term process with the patients or the families. Whereas it's very different in the ICU, because we get to know the families, sometimes very close. The families will be grieving, maybe their loved one is dying, and that we're doing everything we can to help them, but we're slowly realizing that it's just not going to be possible, or that this patient is heading down and their prognosis is very poor, and it just looks like it's time to start getting ready for hospice care or withdrawal of care. And so in that sense, ICU nurses have to really be there for the family members, especially spouses and children and stuff. And there are definite times, many times, where it's late in the evening and everyone's gone, and the family's just standing there, just holding their vented loved one's hand, and they're crying, and you just walk into the room and you just talk to them, and sometimes they'll hug you and even cry with you. Sometimes you'll pray with them. So you have a lot of that kind of intimate moments with family members that I've actually ran into people at Walmart or a cafeteria or something, but later on down the line, months later, and they're like, you're Jason, I remember you took care of my grandpa as he was dying, and you were there with us in the room. And so those moments really make a lasting impact on a lot of patients and their families. And so that's something I really enjoyed about being in the ICU, is having that ability to be there for people in some of their most vulnerable, some of the worst moments of their life, and sometimes some of the best moments when the patients get better and improve and get to go home. Those are joyous moments. So you get to be there for patients in the worst and best moments. So the one personality trait that I think about when I think about the ED is I think of ADHD. ED nurses are usually the nurses who are up and moving and going and, on the move. They want to get something done. They want to go see this next patient. They want to get them discharged. They want to get this next patient in. They're jumping from one thing to the next. They're not wanting to sit down and chart for very long. They're not wanting to, spend a lot of time getting involved in just one patient's, situation. They're jumping from all different areas, and they seem to get bored easy, and they're a lot of fun. They have a lot of times, I would say, as a stereotype, ED nurses are kind of the life of the party, fun kind of nurses. Also the types that if you brought over, they might get, punch drunk and end up having to get Ubered home. They're the types of personalities that are just kind of wild usually. And so, yeah, their personality is very different from an ICU nurse, who's usually much more structured, much more rigid. They don't like a lot of chaos. They do not like to jump from thing to thing to thing. I preferred, if I was going to even get 2 patients for the day, I wanted those 2 patients to be my 2 patients the entire day, or that one patient. I did not like transferring around. I did not like getting 2 patients, spending an hour and a half memorizing all of their lab data, all of their pathophys, looking up disease processes and studying them, things that are going on with the patient that maybe I'm not familiar with, or unusual things. I'm looking up these certain blood type levels the patient has and all this information. If you tell me at 9:30 or 10 a.m. that one of my patients is transferring out after I did all that work and I wasn't prepared for them to move out, and I'm getting a new admission and I have to start all over again, I was frustrated, significantly frustrated. So it's one of those things just very different. In the ICU, you want those two patients, you want to study them, you want to get to know everything about them and their diseases and how you create like kind of a treatment plan up for the day, your goals for the day, whether it be you're going to wean them off the vent, you're going to try and extubate, you're going to titrate down pressors, you're going to do all these different things. You have a goal for what you're going to be doing that day to improve that patient's outcome by the end of your 12-hour shift. And so when a monkey wrench gets thrown in the middle of that, you can get very frustrated. So that's definitely more of a ICU personality and not an ER personality. Another big difference is if you work in the ER, you're always going to have a physician or a nurse practitioner there with you. There's always going to be some provider who's going to be responsible for the overall care of all those patients there in the unit. You're going to have a decision maker. You're going to have somebody who's going to be pretty much giving you orders on like, give this Lortab to this patient and send them home. Do this for this patient and move them here. Take this patient to CT. I want you to do this for this patient. There's always direction. There's always somebody. If you're not sure or whatever, you don't have to like figure it out on your own or really wonder about what you need to be doing, because there's always going to be someone there to tell you what they want you to do. Not to say that in the ER you never have to use your own head and you never have to think for yourself sometimes, because of course every nurse has to do that, and you will have to do that in certain moments in the ER. But overall, you will always have a provider there who's going to be kind of guiding you and telling you what to do. Now in the ICU, that changes, because in the ICU, most ICUs, there are some academic ICUs and some bigger ICUs that have 24/7 in-house nurse practitioners and physicians who just stay and constantly are there rounding and always available, and they kind of help run the show of what's going on. So you don't have to wonder too much if you work in a facility like that. But in general, I worked in probably 8 different ICUs, and I'd probably say over half of them you had to think for yourself a lot of the times in ICUs. You had certain protocols set up. You had maybe certain drugs that you could start if you saw certain situations happening with the patient, whether it be sedation meds. If they had to be intubated suddenly, you had sedation meds, written up like propofol and stuff. You had maybe some neosynephrine or some Levophed orders on standby if you had to have it. Maybe some Dilaudid for pain control, different levels. And of course, these would all be PRN orders, and you would only implement these if the patient needed them. And then you would also later notify the physician that you had to implement these new orders. But essentially, you had a lot more autonomy in the ICU. You had the ability to make a lot of choices. Once those meds got started, you had the ability to titrate these meds. So if you thought the patient needed a little bit more propofol, you could titrate up that propofol. If they needed less, you could titrate it down. Same with your vasopressors and some of your other meds, you would titrate around. So you had that ability and autonomy in the ICU that I don't think a lot of ED people have, because there's always a physician there or a nurse practitioner there. So you don't have to make those choices, because the provider is there to tell you at all times if they think it's a good idea or not. Whereas in the ICU, you kind of make those choices on your own. Or when I say on your own, within protocols, you have guidelines set up, but it also requires a good bit of critical thinking. And honestly, that is one of the major reasons why you have to do ICU, and specifically ICU, to go to CRNA school. That's why they require that, is because it's the only department in nursing where you really make a lot of critical thinking choices, and you have a lot of autonomy, and you titrate meds, and you get to deal with a lot of critical things that build up that kind of clinical thinking and that skill. Alright guys, I think I've talked enough about ED versus ICU. I've only been down to the ED as a nurse a handful of times to help float and just kind of do a couple little odds and ends things here and there. So I'm not proclaiming to be an expert at the ED. This is just from what I've observed and from what my friends who are ED nurses have told me. So I hope you guys have enjoyed this topic. I want to know what you guys think. I'm sure there's quite a few ER nurses and ICU nurses out there who have opinions on the other, one versus the other. So let me know down in the comments below what you think, and if you feel like I got them right or wrong, and what experiences you've had with ED if you're an ICU nurse, or if you're an ED nurse, what you think about ICU nurses. And that's Bolt out.